Dr. Mohler, we have received a lot of questions via email, and I'm just going through them. I see we have touched upon a couple of topics that the questions have come in through. But let us start with the most latest one, recent one that has been sent via email. Dominic wants to know what's promising for men resistant to ABI and Enzo. He is hearing mixed reviews on Galanteron, and he asks, are anti-PD1s the answer?
I can't answer, and nor can anyone else, about whether anti-PD1s are the answer. I would say the short answer to that is no. The anti-PD1s are of great interest right now. They seem to work most effectively in men with advanced castration, I call it recurrent prostate cancer, who have BRCA1 or 2 mutations. But even when they work well, the cancers still find a way to get around the PD1 and PD-L1 inhibitors. So no, they're not going to be the answer, but if you respond well and your response is of long duration, you will believe they are the answer.
Thank you, Doctor. The next question is, can you please discuss treatment for prostate cancer that has transformed into anaplastic?
So this is an area of great interest right now. The NCCN prostate cancer treatment guidelines have been completely redone for advanced prostate cancer with the 2015 edition. Many people believe, my medical oncologist friends, that they're seeing more of these neuroendocrine and small cell cancers, and their hypothesis is that better androgen deprivation therapy using the new agents is resulting in the evolution of these more aggressive, I'll just lump them together as small cell type prostate cancers. Again, this is largely anecdotal. It's unclear whether these cancers should be treated differently than garden variety castration recurrent prostate cancer. In other words, should Taxotere still be or docetaxel still be the primary chemotherapy in any regimen, or should different agents be tried? Again, this is something that resulted in a change in the NCCN guidelines, and clinical trials of these small cell variants are going to give us more information in this regard soon.
Our next listener wants to know, scientists and physicians are contemplating on combining use of several biomarkers for accurate diagnosis of prostate cancer. He wants to know your opinion on that and whether this would increase cost of diagnosis as well as treatment that comes later.
So I assume that your listener is talking about combining the different forms of PSA, which is called the again, I'm so bad on names. It's the H4 score, I believe.
Yeah. 4K score.
4K score, thank you. And there's also the methylation-based tests. So, yes, they cost more than PSA, and the question is it worth the cost? And again, if you can better right-size diagnosis and treatment, they will, in the long run, prove cost-effective. So I'm a big believer in trying to separate prostate cancer as best we can into that which is aggressive and that which is unaggressive. If you're aggressive, then you need treatment. And where I start to have a little bit of a problem with the use of the fancy assays is if I've already had my prostate out and I have a chance of recurring, what advantage is there to me to know whether that chance is higher or lower. Either way, I'm going to worry. And in that space, you got to have a really good test, because to go forward with an additional treatment, you have to be 100% correct that your potentially curative treatment has not worked. Again, I really like PSA for monitoring once the prostate has been removed or irradiated. It's very, very good in that situation. I'm more excited about the use of the more sophisticated tests to select those men who should or should not be biopsied. I don't want to miss an aggressive cancer. And there the question becomes, what's the relative value of the new molecular test versus a 3-parameter MRI? In active surveillance population, I want to be able to reliably tell somebody that it's safe to do active surveillance. So I really think these tests will find their proper spaces early on in disease, and I look forward to that happening.
Our next listener wants to know, could you please elaborate on targeted biopsy and how it is better?
So this is a burning question right now, because if you have a 3-parameter MRI that tells you where a high aggressive cancer might be hiding, you clearly want to stick a needle in it. And you can do that by just putting a needle in the patient under MRI guidance. The only problem is that takes several hours and is very, very cumbersome to do. So the idea is identify the lesion by MRI and then use your ultrasound to place a needle into where the lesion is. Now, there's 2 ways to do that. You can mentally fuse the images. You can work with your excellent MRI radiologist to figure out exactly where in the prostate that lesion is, and then you can perhaps see it by ultrasound. I've had this happen several times now where I go, how could I have missed that once somebody tells me that's where it is? That's called a mental fusion. The other possibility is that you can't see the lesion by ultrasound, but at least you can oversample that area of the prostate. Now you can go one step further and you can fuse. There are now several vendors that have developed software packages that will take the MRI images and overlay them onto the ultrasound images and allow you to target the lesion seen on MRI while you have an ultrasound probe in your patient looking at the prostate. Again, it remains to be seen whether mental fusion is enough or whether you should have an actual software fusion of the MR and ultrasound images.
Thank you, Doctor. The next listener wants to know, what is the reason why PET scans have not been successfully used in prostate cancer diagnosis so far, when this imaging technique has been successful in other forms of cancer?
Yeah, so a PET scan for the detection of prostate cancer has not been very useful. The only place you can get a PET choline PET CT is Mayo Clinic, where it's being evaluated to see whether you can see, using PET, increased metabolism in cancers of the prostate. The basic problem with this, with PET in the prostate, is that the prostate is prone to inflammation. And wherever you see inflammation, you'll see increased metabolism. And the way cancers are recognized is by increased metabolism. So it's going to be very hard to separate the inflammation that occurs in many men due to the stones within the prostate and other reasons from the cancers that might be within the prostate. Now, PET-CT is finding a way to perhaps give additional information beyond a standard bone scan when you do an F18 PET. And also in the research setting, you can label DHT or testosterone and see where it's taken up by tissues, for instance, in the bone marrow that shouldn't ought to be there, taking up, avid for androgens. So I hate to say it again, but there's a lot of work in this area, and PET scanning, though, at this time does not have a clear use for early detection of prostate cancer, and its use for better staging of prostate cancer is in evolution.
So if I may at this point, Priya, I think our hour is nearly up, and I did particularly want to thank Dr. Mohler for his time, but also I wanted to thank him and all his colleagues who work with him on the NCCN for the hard work they put into the constant updating of the NCCN guidelines, because this is done every year, and I'm very aware that it's a great deal of work. So thank you very much for that, Dr. Mohler, and thank you to your colleagues as well.
Hear, hear.
Perhaps you would, if there was one last thing that you would like to wish for that we might see in the next couple of years, could you tell us what that might be?
I'd like to see all these tests that attempt to better stratify tumors in individual patients come to fruition, so that we can realize our goal of truly right-sizing treatment, so that people who need to be treated can be, and those who don't need it, we can avoid these treatments, because all of them, no matter how well done, have side effects.
I would concur with you entirely. I think that would be a wonderful thing. Priya?
Dr. Mohler, thank you very much for being with us today. Mike, Tom, and Paul, thank you for your participation, and hope all of you will join us again for Cure Talk's next talk on prostate cancer, which is scheduled for March 19th. We will be discussing clinical trials to enroll in with Dr. Maha Hussain of University of Michigan. Please visit our new website, curetalk.com, for information on our upcoming shows. The link to today's discussion will be sent via email to all the participants. We'll be putting up a transcript of the show too on our website very soon. Thank you very much.